I will welcome also our authors, two of four, right? Two of four. Lisa Fischer, it's very nice to have you here, and Michael Hartwick. Right?
Thank you so much for inviting us.
It's great to have you here. Lisa Fischer é docente clínico do Departamento de Medicina de Emergência e do Departamento de Cuidados Paliativos na Universidade de Ottawa, e o Michael Hartwick é professor assistente do Departamento de Medicina Intensiva e Medicina Palliativa na mesma Universidade de Ottawa. A Joana Mapril é médica de Cuidados Intensivos e mestranda em Cuidados Paliativos aqui na Católica. Bem-vindos, welcome. Obrigada. Passo a palavra à Joana. Muito obrigada.
Bom, então boa tarde. Antes de começar a apresentação do livro, eu gostava de agradecer ao professor Manuel Vila de Capelas por me ter lançado este desafio. Eu sou internista, sou intensivista, e nos últimos dois anos senti necessidade de melhorar as minhas competências para lidar com situações de fim de vida. Comecei por fazer alguns cursos básicos de cuidados paliativos e de comunicação, e em outubro me inscrevi aqui no mestrado de cuidados paliativos da Universidade Católica. E por isso é obviamente para mim muito gratificante poder estar aqui a contribuir para divulgar este livro, que considero um contributo importante para a formação nesta área, e por outro lado é também muito gratificante estar aqui a partilhar este debate com colegas que, trabalhando na área do doente crítico, têm já experiência na integração dos cuidados paliativos na sua prática clínica e têm trabalho de investigação desenvolvido nesta área. Bom, o livro que vou apresentar chama-se Palliative Care in Non-Cancer Patients, AIDS, Critically Ill and Neurological Diseases. Faz parte de uma coleção de livros editados pela Universidade Católica sobre o tema dos cuidados paliativos, e é o primeiro de 2 volumes sobre a doença não oncológica. E como o professor Manuel Vila Capelas diz muito bem no prefácio, os cuidados paliativos nas últimas décadas sofreram uma enorme evolução e deixaram de se considerar e de ser considerados como cuidados prestados apenas ao doente em fim de vida, para passarem a ser cuidados que são adequados para qualquer doente que tenha uma situação ameaçadora da vida, independentemente de poder ter indicação para fazer terapêuticas curativas. E, portanto, este livro vai cobrir algumas populações que habitualmente eram excluídas do âmbito dos cuidados paliativos, como, por exemplo, os doentes internados através do serviço de urgência ou os doentes admitidos numa unidade de cuidados intensivos. O livro está organizado em 3 capítulos. O primeiro capítulo sobre cuidados paliativos na doença neurológica, o segundo, cuidados paliativos no doente crítico, e o terceiro, cuidados paliativos na infecção VIH-Sida. O primeiro capítulo é da autoria do professor David Oliver, com quem nós mestrandos de cuidados paliativos tivemos a felicidade de ter aulas. Aliás, devo dizer que todos os autores deste livro são docentes da Universidade Católica e são professores deste mestrado em cuidados paliativos. E como estava a dizer o professor David Oliver, é médico, é especialista em medicina paliativa e tem uma longa carreira já dedicada especialmente à doença neurológica. Dentro da doença neurológica, a sua principal área de interesse é a doença do neurónio motor e a esclerose lateral amiotrófica, e de facto tem imensa publicação em termos quer de artigos científicos, quer de capítulos de livros e mesmo livros sobre a doença do neurónio motor, e é portanto uma verdadeira referência nesta área. E este capítulo começa com uma descrição das particularidades em termos dos cuidados paliativos na doença neurológica, e depois porque os vários tipos de doença neurológica são muito diferentes entre si, vai fazer uma descrição de 6 tipos principais, ou 6 grupos de doenças que têm características diferentes, e vai apresentar para cada uma delas as suas principais necessidades paliativas e também as estratégias que estão recomendadas para lhes fazer face. E vai descrever, nomeadamente, a esclerose lateral amiotrófica, a esclerose múltipla, o acidente vascular cerebral, a doença de Parkinson, a doença de Huntington e as demências. E um aspecto também que achei curioso e muito útil é que para cada uma das doenças ele apresenta os triggers que nos fazem pensar que o fim da vida se está a aproximar e que são os triggers que nos devem levar a rever os nossos planos de cuidados, a conversar novamente com a família e a preparar esta fase da vida dos doentes. É um capítulo que está escrito de uma forma muito clara e que acho que é muito útil para quem trata este tipo de doentes. Depois deste capítulo, segue-se o capítulo dos cuidados paliativos no doente crítico, que é da autoria do professor Michael Hartwick e da professora Lisa Fischer, já apresentados pela doutora Adela Antunes, e de uma forma muito inteligente os autores apresentam-nos este capítulo apresentando-nos a uma senhora idosa, Mrs. Josephine Howell, que é uma senhora que é ainda independente, vive sozinha, mas que é uma doente, como nós conhecemos no nosso contexto também, com muita patologia. É uma doente com uma insuficiência cardíaca congestiva, com uma fração de ejeção inferior a 20%, com uma fibrilhação auricular, uma doença renal crónica, com uma longa lista de medicação, como estamos habituados a ver, e inclusive com um cardiodesfibrilador implantável. E nós vamos acompanhá-la ao longo de uma descompensação, desde a sua abordagem pelos serviços de emergência a nível pré-hospitalar, passando pelo serviço de urgência, pela unidade de cuidados intensivos de onde tem alta e depois quando é abordada pela equipa de emergência intra-hospitalar durante um novo agravamento dentro do hospital. E ao seguirmos o trajeto desta doente, para já nós somos imediatamente transportados para a nossa prática clínica, não é? Para os doentes que nós conhecemos e para o ambiente onde estamos habituados a trabalhar. E por outro lado, os autores vão-nos salientando as necessidades paliativas em cada fase e em cada tipo de abordagem, a forma como devemos abordá-los, e depois vão-nos apresentando tópicos importantes na abordagem paliativa do doente crítico, como a importância do reconhecimento precoce dos doentes de risco, como a necessidade de haver planos de cuidado centrados no doente e na família e diretivas avançadas de vida, como é que devemos fazer a integração, e apresentam-nos alguns modelos de como é que devemos fazer a integração dos cuidados paliativos, quer no serviço de urgência, quer na unidade de cuidados intensivos, e depois também resultados dessa integração, resultados outcomes já medidos em investigação científica, e terminam com alguns aspectos específicos do controle de sintomas a nível dos cuidados intensivos e também de alguns aspectos particulares dos cuidados intensivos, como seja a retirada de terapêuticas de suporte de vida. Ao longo de toda esta análise, os autores vão revendo a bibliografia existente, vão apresentando uma bibliografia selecionada que é extremamente útil para pessoas que, como eu, querem aprofundar conhecimentos nesta área e querem depois fazer este trabalho de integração também no seu próprio local de trabalho, no sítio onde, na sua unidade de cuidados intensivos ou no seu serviço de urgência. Finalmente, o último capítulo é o capítulo sobre os cuidados paliativos na infecção de VIH. É apresentado pela professora Liz Whither, que é médica de Medicina Geral e Familiar, é mestre em Cuidados Paliativos, é docente, é assistente convidada da Faculdade da Universidade de Cape Town e é atualmente chair da Worldwide Hospice and Palliative Care Association, e que começa por nos apresentar os números que ilustram aquilo que é hoje considerada uma verdadeira epidemia do HIV, apresenta-nos os números dramáticos do continente africano e particularmente da África do Sul e compara-os com a nossa realidade portuguesa, e depois apresenta-nos a própria doença, enfim, algumas noções sobre a infecção VIH e a sua evolução, e vai salientando as necessidades paliativas associadas e as estratégias que devemos ter para lhes fazer face. Bom, em resumo, este livro é, na minha opinião, um contributo muito importante para a formação em cuidados paliativos e considero que é uma ferramenta que, muito útil, quer para médicos destas diferentes especialidades, da neurologia, da infecciologia ou dos cuidados intensivos, que queiram integrar os cuidados paliativos na sua área, mas também é muito útil para médicos de cuidados paliativos que tratem este tipo de doentes com esta patologia específica. Portanto, é um livro que eu acho que está muito bem escrito e que recomendo vivamente. Terminando a apresentação do livro, vamos passar ao debate, e aqui eu vou ter que usar uma cábulazinha para não me engasgar nas perguntas em inglês. Thank you again for being here with us and sharing a little bit of your knowledge and of your experience with us. I will now make you some questions so we can explore a little bit more your chapter, since I just gave not too much information, so we will be able to hear it from you. And I would start with you, Professor Michael. One of these days, one intern in my ICU, knowing that I was making the master on palliative care, asked me, does it make any sense, palliative care in the ICU? Is it not a paradox? Could you tell me how did you answer this question?
Sure. We discussed this question this afternoon, and I joked that I feel like I've been discussing this question for 10 years. I began fellowship combined in critical care and palliative medicine in 2007, and this was a question that was raised often. I think one of the immediate responses is to just talk about the prevalence of mortality in critical care. In our units in the hospital where Lisa and I work in Ottawa, our ICU mortality ranges from high teens, 18-19%, to low 20%, up to 25%, and that's pretty consistent across other units our size in our country. And so an immediate response could be, if any of your patients, if I told you any patient in your unit was going to have one condition 1/4, 1/5 of the time, wouldn't you want to learn more about that and study about that and know how to better care for those patients? If it was heart disease, kidney disease, diabetes, of course the answer is always yes, I would. And so if I said to you, we know that 15, 20, 25% of your patients will die in your care, would it not be important then to learn more about palliation, how to look after these people, what are their needs, what are the needs of our unit, of our fellow colleagues, and to develop that and get better at that. So I think it's not a paradox. In fact, it's an essential piece and always has been a piece of the care we provide. So that would be my first answer, and I'm happy to follow that up further.
Well, one of the challenges in palliative care with the critical ill is to have goals of care discussion, because usually our patients don't have this kind of discussions before they have a crisis, and then when they are admitted to the ICU, they are too sick to be able to plan for the future or to make decisions, and sometimes they can't even communicate. In your hospital, do you have any system, any process to overcome this, like on admission or?
I think it's something that Lisa and I can both answer to, but it's something that we're trying to address. I don't stand here and say that we have that solved in any way. We've been talking a lot in Canada about advanced care planning, We know that it's something that we need to continue to promote, to help people to both discuss their wishes, their values, how they would see the care at the end of their life, things that they may want or not want to see happen, and to discuss those with their family, ideally to document them in a way so that in crisis people can draw on those. We know also that those plans are often made before context, and then when somebody presents to their doctor, when emergency services call, they come to the emergency department or they're admitted to the ICU. We have to readdress that. We have to discuss what is the situation now. What have you talked about before in terms of these values? Do you have them written down for reference anywhere? How can we translate that into a care plan or goals of treatment for the hospital? And how can we propose a plan of treatment for your consent or for the consent of your substitute decision maker, appointed power of attorney if they have one, that we can then proceed with of course the advice of the medical professionals that you've come to see. We try to have those records come with people from their care setting before to the hospital. We have a policy that those discussions happen and a way of documenting that policy. But whether we look across the country or even in our own institution, we know that we're not perfect in that. And we either fail to revisit that conversation in contexts, fail to document that conversation, fail to have a conversation that is understood correctly both ways, where that documentation actually reflects the person's values and the advice and what's possible in the hospital, and that communication has occurred. So that's the piece that we're trying to improve. Some of it is institutional and healthcare policy. Some of it is individual behavior, where we each have to take the initiative to see that it's done. And some of it is adapting our systems to enable that. And we talked today in class about having a system that is transparent across multi-levels and flexible and adaptable to the reality of each of those levels. And that, as it is a challenge we understand here in Portugal, it remains a challenge for us in Canada as well.
But you have a model or a form that like some colleagues from Alberta told us that they have this form that is always on this green
the green sleeve, yes.
The green sleeve, and it's always on the fridge, so it has lots of codes that the pre-hospital emergency team can find it. Do you have something like that also in place?
We do have similar such forms. One of the issues that we encounter is that the forms currently are different for different contexts. So the nursing home may have one form, a community hospital may have another. There may be a different provincial form that exists in the home, all of which may be brought to the institution, in the case of our hospital, which has its own form, and those each need to be translated into an actionable plan. We are trying more to integrate these things into our health record, as I said, that can be seen across multiple settings, but that of course prevents many challenges, and you may be able to control it within your own sphere of your own healthcare institution or corporation, but not necessarily others. And so yes, we do have a form, but those remain challenges for us as well.
Well, maybe I can ask you now, so I can leave Professor Hartwick a little bit more rested now. The emergency department is, in my understanding, the most challenging place. As you said in the book, it is noisy, it is busy, we have no time, people are frightened, and they don't know us. How, in your daily practice, because you do it
usually how can you manage to overcome all these barriers?
Thank you. It's a very good question, and it's something that I've thought about a lot. And to answer that question, I think first I want to thank Manuel and Annabelle for publishing this book, because it's by getting the message out that palliative care can be integrated in non-traditional settings that's going to help eliminate some of these barriers. As I said in the course today, the history of emergency medicine, came from resuscitation and life-saving, and that's one of the reasons why people choose to work in the emergency department. But the reality is that that situation is only encountered about 3% of the time in your daily job as an emergency physician. Patients come to the emergency department often on the worst day of their lives. They're suffering from many different ailments, physical suffering, psychological suffering, and your job as the emergency physician is to identify that suffering and try to make that person feel better. And who does that better but palliative care physicians? And so I think there's a lot that emergency department workers can learn from palliative care in that sense. The barriers that I see, and we talk about in the book, we categorize them in mainly 3 domains. One is, the patient, and it's what you've alluded to, and I think as healthcare professionals, we don't have a lot of control over how a person is feeling in the emergency department, being scared, being afraid, being alone, encountering a lot of strangers. The other barrier is the environment, which also you don't have that much control over. It's loud, it's noisy, and you don't have a lot of time. I think the average interaction a physician has in the emergency department with a patient is 6 minutes. And so that's challenging to deliver good care in 6 minutes. And so, but what we do have control over is yourself as the provider. And so first, by recognizing that it's everyone's job to take care of the patient in front of you, and by not thinking that it should be the family doctor, or why isn't the oncologist, or why is this person even in my emergency department? Well, they're here and you need to take care of them. And then the other way I think we can break down the barriers is by education. So books like this, there's been lots of research, predominantly from the US, but now in Canada and hopefully outside of Canada too, around emergency practitioners want to have better training in palliative care. They do see it as their role, and we need to incorporate it in medical student teaching, residents, and even postgraduate. So that's how I'm hoping to attempt to start breaking down the barriers, and I do see change over the last few years. I think we're making progress.
It's more like a change of attitude more than anything else, isn't it? Yeah. But you are already further away. You're in the pre-hospital setting, isn't it? You're doing lots of research about palliative care, bringing palliative care in the emergency, in the pre-hospital emergency system. Could you tell us a little bit more about it? What is it? What is happening now?
Yeah, I'd love to. Traditionally, my experience in palliative care has, I think there's great delivery of community palliative care, and then, we work in an acute care hospital. And as I was doing my training, I thought, well, how does someone get from the community to the hospital? Well, they often interface with paramedics, so emergency medical systems, and then via the emergency department to the acute care. And so, we also know that most people want to stay at home well, comfortable, as long as possible, and maybe even die at home. And there's lots of literature that says that about 70% of people would choose end-of-life care at home if possible. But unfortunately, it's actually the reverse that's true. 70% of people are dying in hospital. And so how can we keep people home, and how can we bring care to the home instead of bringing people to palliative care? And that's what really started my interest in pre-hospital palliative care. I know that there's a lot of differences in North America and how pre-hospital care is delivered in Europe, but what I find extremely exciting about the model that's in Portugal is that you have physicians and nurses who are going to people's home to provide care, and then often transporting to hospital, but also often choosing to leave people at home. And that's not true in North America. almost 99% of times, by law, paramedics are obliged to transport patients to hospital, even if it's as simple as someone had a low blood sugar and it was fixed. They still need to bring the person to hospital to then see someone like me to say, yep, you had low blood sugar and now it's fixed and now you go home. So despite those limitations, though, over the last couple of years, there's been exciting changes in how we deliver palliative care with interfacing with paramedics. There, in a few Canadian provinces, I was part of developing curricula that trained all paramedics into learning the essential applications of palliative care. And they're now providing palliative care in the home, currently right now in 2 Canadian provinces. And whereas 99% of the time patients were transported to hospital, now 70% of the time patients are staying at home, which echoes the 70% that I just spoke about. And what's not in the book, which I'm really proud to say, is a result of those initial projects that I was a small part of, and people have invested a lot of time and energy into growing those models. On February 3rd, just a few months ago, it was announced that the same model was going to be developed in 5 other Canadian provinces with a federal grant of like multi-million dollars. And so I really think that paramedics are an underutilized healthcare member of the team. And I really think it can provide a meaningful difference in how we deliver palliative care in Canada. So I'm very excited about that.
Well, I still have one question, but I think that maybe if the audience wants to make any questions, I think it would be nice to change some, well, no? Well, so I'll make my last question. In the book, you told us about 2 models of integrating palliative care in the intensive care unit. The integrative model and the consultative model. What I would like to ask you, if you could explain a little bit of these 2 models and their advantages and disadvantages, and which one would you advocate?
Okay, let me start with the beginning. The 2 models proposed in the literature, the consultative model being the model where you have an existing palliative care service in your institution or in your community, and that becomes a resource for your critical care unit for consultation. The other being integrative, where in some way you build into your critical care services personnel who are cross-trained or have a particular expertise in critical care to grow and live within it and provide those services within your critical care delivery at your institution. The advantages and disadvantages as described are that the consultative model may make use of already existing services that you have anyway, so in that way may be less consumptive of resources and time to build that, may allow that service to serve other purposes in your hospital, in your community, but as a disadvantage may always feel or be seen as outside, that their reality is not the reality of critical care services, is not what happens in the emergency department, is not what happens in the ICU, and they are outsiders, both in their own feeling about what they may offer and in perception about how they understand the context of acute and critical illness. The integrative model is obviously the reverse. They are by definition integrated and inside, and so perhaps those real or perceived barriers will be taken down. But they require the investment of educating, of developing, of funding, of growing that service from within, and may not then serve outside that environment. So you may still need, of course, those other services to exist outside the acute care areas to care for those patients who are not in acute care, but also to transition patients out of acute care too. So that would be the description of the two models. So, come to my opinion, what would I advise? I've spent a lot of time trying to solve that problem. We have both in Ottawa. We've had the luxury of having both. We have palliative care consult team that works in the hospital. We have palliative care units within the city. We have community palliative care providers, all of whom could be consultants to our acute care areas. We have had the great privilege to develop people within our units, within emergency medicine, Lisa and her colleagues, myself and some of my colleagues in Ottawa. And so I think we've had a bit of a chance to see what both looks like. All that being said, I've really come to believe more in a system theory for healthcare in general, and that imposing our system into another system is not likely to work. And so I think the greatest thing to do is to identify that this has importance and need, as you've done, as exemplified by having people come to this room to discuss this, come to a course over years to talk more about it, and we said at the beginning, Lisa and I learn and take things back every time from you guys as well. But think about the fact that you think this is important. You have a growing community of people who see the value of this, and then ask the question, what is our context? What are the ideas that we think would work here? What are other ideas that might only work here and are necessary here in Lisbon or in Portugal to grow this? So I don't recommend one model in particular. I think they have their strengths and usefulness, and you may have constraints in your system, as we do in ours, imposed by legislation, professional societies, resources, human resources, physical resources, financial resources that dictate what you can do. So I think the initiative is the important part. The access to information, the sharing of information, as we're doing now, is what moves it forward. I'm sorry if that's an opt-out answer, but I believe it's true.
Actually, when I was reading, I thought, and you talked also about a mixed model. I think some integration has to exist, because we have to recognize the needs and we have to address them immediately when we are treating our patients. So some integration has to exist, and everybody has to have some basic knowledge and about communication, about symptom control, about advanced care planning and goals of care. And so, but it is difficult, and talking about resources, it is difficult to have a whole team inside the ICU. Like have the psychologist, the social worker, everybody. Although it's useful that they are trained with these particular patients, with critically ill patients, and with that context. So, well, I think the best would be to have it all working in team, inside and outside, with the consultants and the ones inside integrated and with knowledge, I think.
And a lot of those things some of their role is in helping us provide palliative and end-of-life care, but of course many of these things we need for all aspects of care that we delivered, and we talked about that today, that it's sort of symbolic that both intensive care, emergency care, they all end with care, right? And so we need these people ideally, and we're all constrained by our resources to provide the best care we can to our patients. We've all, I think, growing to a place where we acknowledge that having good communication, having communication is an essential part of the care we deliver, thinking about both the patient and their values, and supporting their family, supporting our colleagues, managing people's symptoms while we do all these things, addressing end-of-life issues. is part of the care we provide across the spectrum of healthcare. So it would be wonderful to have those tools all the time, and so anytime you can get those tools as your situation allows, then you can put them to work in lots of different areas.
I don't know if anyone has a question now?
As we are talking about tools, I've been working in transplantation or organ donation. I know you're going to speak about it tomorrow, but still maybe we could just mention it now in this moment. In transplantation medicine, and now that I'm learning about palliative care, I think I wish I would have known that these years ago when I spoke to the patient, to the family, not the patient, to the family, when I spoke about organ donation. It's extremely helpful as a tool. I would like to know, in your career, what did you start? How do you feel about this combination of organ donor and palliative care, and how do you combine it?
It's been like most things, an evolution. I now work with our organ donation organization in our province, Trillium Gift of Life, as one of their regional medical leads, and it was a growth over time, in so much as because of my interests in medicine generally, in critical illness, in palliative medicine, this became a natural interface. Of course, by definition, these are patients that will die, and who have, as part of their end-of-life wish, indicated, or their family has indicated, that they wish to donate their organs to others. So it's all tied into the same theme. In fact, so much so that our provincial organization has now taken the position, and our national organization, that the opportunity, not necessarily to be or not to be, but to have the opportunity to consider organ and tissue donation is part of offering quality end-of-life care. And framed in that way, we think about it as similar to other things that may be important to people at the end of their lives. The place in which they wish to die, the kinds of interventions they wish to receive or not to receive, social, spiritual factors that may be important to them. This may be another piece that we need to consider in the dying, in making patients dying as meaningful to them and their families and their communities as we can. So it was a natural piece. In terms of my own personal evolution, I started by being part of those cases often, by being asked to come and be part of a council, a provincial committee that met a few times a year to discuss these policies, to being officially hired as one of our professional organ and tissue donation physicians in the province, and have continued that evolution and career, and that you end up getting invited to nice things, to plan around these things and try to shape this for the province and the country. So that's how I came to it, and came to recognize that, yeah, this is part of this whole discussion.
I don't know if there are any more questions from the audience. Well, if not, maybe we will close the debate. Thank you very much.
Well, thank
for
you
being
always
here.
for asking us and letting us be part of this. It's wonderful.
Thank you.